Tell us how you evaluate and manage myalgias and arthralgias associated with immune checkpoint inhibitors. Musculoskeletal disorders occur in up to 20% of patients on trials. However, most clinicians feel that this is actually underestimated because mild cases are not always reported. Arthralgias range from 1 to 43%. Other musculoskeletal and rheumatologic AEs are less frequently reported. However, they have been reported across trials. These may include inflammatory arthralgias with synovitis, exacerbation of rheumatoid arthritis, polymyalgia rheumatica. Myositis is a more significant form, and that's occurred in 0.4 to 6% of patients. It has been reported as early as 1 week after immune checkpoint therapy initiation. In very rare cases, there have been immune-mediated necrotizing myopathy reported. There's also been giant cell arteritis reported. These arthralgias and myalgias are more commonly reported with PD-1, PD-L1 inhibitors, and less so with CTLA-4. However, keep in mind that they will occur in combination therapy. Overall median onset is 1 month to 9 months. The differential diagnosis for myalgias and arthralgias is that it may also be an indication of an underlying autoimmune disease, so it's important to evaluate patients for that potential. Often patients that have an early stage or early grade of rheumatoid arthritis have not been officially diagnosed at this time. Physical examination is important when one is looking at arthralgias. How many joints are involved? What is the patient's functional assessment, or is their ability? Do they have weakness? Is there pain limiting their activities of daily living? Laboratory assessment for arthralgias includes an ESR level, so erythrocyte sedimentation rate, a CRP, which is your C-reactive protein. In addition, creatinine kinase and aldacase are required for myositis and myalgias. In severe cases, you should consult with a rheumatologist as advanced rheumatologic management may be necessary. In cases with multiple joints involved, X-rays, joint ultrasound, or MRI of joints may be required. In early grades, so low grade of arthralgias and myalgias, the treatment of choice may be non-steroidal anti-inflammatory drugs, and immune checkpoint therapy may continue. In more severe cases, one might require holding the immune checkpoint inhibitor and initiating steroid use. So that would be corticosteroid at 1 to 2 milligrams per kilogram per day until resolution to grade 1. In some cases, if there is significant increase or higher grade toxicity, patients that are unresponsive to initial steroid use may require dose-modifying anti-rheumatic drugs, and this may include hydroxychloroquine or methotrexate. Important to monitor those patients for their ADLs and ability to care for themselves at home, as they may require physical therapy and occupational therapy referrals to manage their activities.